We start with the first lecture from Takao Itoi, Tokyo, Japan. Will be moderated by Claudio De Angelis from Turin, Italy. And the lecture that is pre-registered will be, will US replace ERCP for drainage of malignant distal biliary obstruction, where we are?
So thank you very much for kind introduction, Albert, my good friend. So I showed my slide. Okay, let's get started again.
Hello, everyone. I'm Takao Itoi from Tokyo Medical University. Thank you so much for giving me the opportunity to talk on this topic. As you know, USBD has been reported in 2001 by Professor Marco Giovannini. In other words, this year marks 21 years since the USBD was developed. There are two main techniques of USBD, namely cholecystectomy as extrahepatic bile duct drainage and hepatico-gastrostomy as intrahepatic bile duct drainage. Which one is better? Numerous papers have been published until now. I think there is no significant difference if the endoscopic unit has US experts. Main indication of USBD is in case of failed ERCP, namely failed biliary conversion or inaccessible papilla or anastomotic site. So simply, which one is better, ERCP or USBD? Here, you can see the pros and cons in each drainage. Most important point describe red words. In terms of ERCP, it has been already established procedure from many years ago, and there are a lot of skilled endoscopists to do this procedure in the world, but it may have a possible post-ERCP pancreatitis. On the other hand, in terms of US, it has no post-ERCP pancreatitis theoretically, but there are few skilled endosonographers in the world. So one recent prospective multi-center study in Japan showed US CDS using a covered metal stent as primary biliary drainage was technically feasible, and its safety appears comparable to transpapillary stenting. So let's see the latest high evidence. Currently, there are several high-quality studies. Firstly, let's see the RCT one by one. So Professor Fowles and Shyam group studies from USA showed USBD is practical alternative to ERCP or primary biliary decompression in pancreatic cancer. Another study from Korea showed same outcome. In terms of tumor ingrowth, USBD may be better than ERCP. In contrast, in terms of food impaction and center migration, ERCP may be better than USBD, but not statistically significant. This is another study from also Korea. In this study, USBD included not only CDS but also HGS. In terms of technical success, USBD is same as ERCP. In contrast, in terms of clinical success, patency, adverse event, re-intervention, and QOL of a patient, USBD is better than ERCP. Interestingly, Professor Recipe and his colleague advocated this study is unfair for ERCP because of overrated adverse event, and USBD is still difficult to replace with traditional ERCP. So let's move on to the systematic review and meta-analysis. So you can see the representative 5 studies. So technical, clinical, and overall adverse event are same between EUS and ERCP. In terms of post-ERCP pancreatitis and re-intervention rate, USBD is significantly better than ERCP. 4 years back, one consensus guideline by world-renowned endosonographer has been published in Journal GAD. One statement includes USBD. As you can see this slide, USBD is recommended as a procedure of a choice of biliary drainage in patients with failed ERCP if expertise is available. It is a very important point, as I mentioned. So, however, next year, as a world-renowned endosonographer advocated that USBD was not yet perceived as the initial procedure to relieve the unresectable malignant biliary obstruction. Various USBD methods were regarded as having different efficacy and safety. The superiority of USBD over PTBD was not in agreement. Refining the procedure, development dedicated devices, and gaining expertise in the procedure are necessary to popularize USBD. I think I totally agree with this conclusion. Thus, based on the evidence and our experience, the question, can you replace routine ERCP with USBD? I have to say no, still no. Nevertheless, USBD is preferable in some situations. When we should consider USBD, I think, for example, gastric outlet obstruction or surgical altered anatomy. In case, we should consider USBD. So as you can see, USBD can be performed with high degree of clinical efficacy and shorter procedure times than endoscopy-assisted ERCP in patients with surgical altered anatomy. Also, several studies showed the efficacy of interventional EUS in surgical altered anatomy. So what does it take for USBD to be the first-line drainage method? I think, first, if possible, dedicated US scope is preferable. Second, sophisticated and dedicated devices for USBD are mandatory. Third, simplified USBD procedure is ideal. As you know, we just developed dedicated interventional EUS scope provided by Fujifilm. There are 3 or 4 advantages. One is a possible perpendicular puncture. Perpendicular puncture is possible, and wide endoscopic view, which enables the easy stent deployment in the gastric side. and less blind US imaging. That so contribute less complication like intervening blood vessel puncture or GI wall or the vessel puncture. And the guide wire locking system is also very nice system to avoid unnecessary guide wire removal or others. Good for the assistant. So another point is simplify dedicated devices. One-step device like hot lamps for USCDS is one of the possibility of a successful USBD. So our prospective multi-center study showed a relatively nice outcome, and also the one multi-center international study is also showed comfortable outcome using these hot lamps or USCDS. So in the future, we are very looking forward to knowing the RCT outcome between hot lamps and standard tubular stent. Another one-step stent for both UCDS and HGS has been reported. I also look forward to using this kind of dedicated stent, which allows easy and simple USBD procedure. There are several limitations in this field. Few expertise of US compared to ERCP, and a complicated strategy due to various malignant biliary obstruction, in particular in case of terapeutico gastrostomy. And still, we have few dedicated devices for this procedure. Ladies and gentlemen, in my conclusion, outcome of USBD is similar to regarding a part of adverse event better than those of ERCP assisted biliary drainage as a first-line treatment. However, it is limited only in the unit in which US expertise is available. So finally, I think a dedicated scope device and the established technique mandatory for the first-line biliary drainage. Thank you very much. Thank you for your kind attention.
Thank you very much.
Okay, congratulations, Professor Takao. This is a very beautiful lecture, and I think also well balanced. I would like, first of all, to thank the course directors, Alberto Larghi and Jacques van der Merwe, for this kind invitation, and good day to all that are online with us in this moment. Over the last decade, a wealth of data allowed US biliary drainage to emerge as a welcome alternative to percutaneous drainage after failed ERCP or after surgery, and also as an alternative to pre-cut after failed cannulation. But the question today was if you will really feel that US biliary drainage will become the first-line treatment for biliary drainage, at least in patients with malignant distal biliary obstruction, so replacing ERCP as first-line treatment. And really, you tell us very well that there are some limitations still today for this technique because of a limited number of devices, and also some limitation of the EUS operative instrument that we have. But in your feeling, really, in the next 2 or 3 years, do you think that this reality, this new challenge of EUS will become a reality as first-line treatment or not? At least in high volume centers.
Yeah, thank you very much. I really think it is not so prime time to perform biliary drainage of by USBD as a first-line treatment because so standard ERCP is much I think much safer for all of endoscopists. Of course, in particular in patient in case in unit of expertise unit, so USBD maybe is similar, not the first-line, the same even ERCP and the USBD, but in the most of institution, maybe ERCP standard ERCP is still gold standard.
Yes, I can agree with you, but for sure, the high number of adverse events for the US guided biliary drainage, I think that in the last studies has been demonstrated that can be reduced so much with the new lamps. That can make us able to reduce the number of passages that we must do to perform the biliary drainage under US guidance. And this can reduce very, very much the number of adverse events. I have some question from the audience from Italy. Alberto Pantin tell us that the ESGE guidelines today recommends US biliary drainage for malignant distal biliary obstruction only when the ERCP fails. So I think that this is true. When ERCP fails, it is clear that today, if we have the expertise, we must use US drainage. But do you think that in the next 2 or 3 years, these guidelines can change in favor of USBD? With the lamps.
Yes, if all over the world endoscopist, endosonographer can use lamps, hot lamps, in particular hot lamps for CDS, I think you are right. There is a possibility of the hot lamps for US CDS as a first-line treatment. But you know, I have a lot of experience as well as you for the CDS with using lamps. Sometimes the deployment is difficult. I've seen the misdeployment in the bile duct or the misdeployment or dislodgement from the bile duct to the duodenum of the distal branch during the even live demonstration by expertise. So still, I guess not perfect using lamps, even using lamps. That's why. So we have to take care. Hot lamps is a very nice the devices, but for the beginners of USBD is not so always successfully performed, successfully deployed. I think that's why. So we have to take care of the data of the article. Yeah.
Okay, thank you. And do you have any experience about the new hot devices for hepatico gastrostomy that could simplify also this technique?
Yeah, in terms of the US guided hepatico gastrostomy, almost all cases we perform US HGS because almost in our unit we perform USBD for the gastric data obstruction. That's why. So mainly we perform US HGS. At that time we already established the US HGS technique. In Japan, you know, there are a lot of sophisticated devices to dilate it. Tract, needle tract. So, for example, a very thin tapered mechanical dilator, or a very thin small or dilating balloon, or recently, you know, lately we can use spiral dilator, like a 300 dilator long type. So,
Okay.
so using such kind of sophisticated devices, I guess US HGS is very safe and very comfortable for USBD technique. But even though in case of small duct, sometimes very difficult to perform.
Thanks, Takao. Thanks, Claudio. I want to just say that you know, you're both ERCPs first, and then you learn US afterwards. Being an US users and being got adjusted to LAMS since they came out in 2011. In my view, a drainage of the bile duct in 3 minutes, avoiding pancreatic acute pancreatitis, with probably some changes in the stance. So we are at the early phase. I think they will for sure bring US biliary drainage to overcome ERCP. I think it's a matter of time. But thank you for your intervention. We have to move. We move to Korea, where there's going to be Dongwon Seo from Seoul. Will be moderated by Marc Parte from Marseille, France, but I think he's in Lebanon right now, in Beirut. And Seo will talk about US guided ablation therapies, indications, and long-term results. Hi, Dongwon.
Ciao.
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 Hi, Dongwon.
Good morning. Yeah.
Thank you.
So now we are very pleased to introduce Dr. Dongwon Seo.
Yep.
He's going to speak about US guided ablation therapies, indication, and long-term results. So it's up to you. I just to say that I am actually in Lebanon, so I hope the connection will be okay. I'm doing a workshop in Lebanon. Okay.
I'm also in Turkey, so I'm worried about the connection issues. So they will play my pre-recorded video.
I just want to add something to the comments from Alberto. This is very important, the training of both USCP and EOS. And really, I started at my time with both EOS and USCP. I think we have to manage biliary and parte disease and not a procedure, not a technique. So we need to be able to do both EOS and USCP if we want to treat any patient with biliary and parte disease. And this is very important. USCP is not more important than EOS, and EOS is not more important than USCP. So we need clearly for the new generation to have the both training for EOS and USCP.
My real pleasure to join this wonderful meeting, EOS Skyline. My special appreciation goes to the organizers of this meeting. The title assigned to me is EOS Guided Ablation Therapy, Indications and Long-Term Result. EOS Guided Ablation Therapy can be divided into two categories, solid lesion ablation and cystic lesion ablation. Our group is very much experienced in ablation of pancreatic cystic lesions, so today I'm going to focus on pancreatic cystic neoplasm ablation. Indications, cases and technical details, and the result of cyst ablation will be discussed. Indications first. When we first started EOS guided ablation therapy, we applied very strict inclusion criteria. It is because we did not know what will happen after EOS guided ablation, the efficacy and the complication profiles, etc. So we included only unilocular or oligolocular cystic tumor, size ranging from 2 to 5 cm. It is not based on MCN or SCN IPMN like true histology. We don't know true histology at the time of ablation. Only presumed diagnosis is available. And exclusion criteria are as follows. Based on clinical history and image findings, if pseudocyst is suspected or serous cyst adenoma is suspected, then we exclude it. And overt cyst adenocarcinoma or IPMN showing clear communication with main pancreatic ducts were all excluded from this study. In the year 2011, we tried to analyze our long-term follow-up data and published it to gastroenterology. And during this study period, we understand more about the technical details of EOS guided ablation and the result of ablation and also the safety profiles. And we try to expand our indications. These are our group's recommended indications. Unilocular or oligolocular cystic tumors are the best target, and the size ranging from 2 to 6 cm would be good, but it is not absolute. We can target even larger cystic tumors. Presumed diagnosis of MCN or SCN or indeterminate cyst may be a good target, but a cyst should not have clear communication with MPD and without evidence of malignancy. Let me move on, cases and the technical details of the procedure. This video shows the techniques of EOS guided ablation of pancreatic cystic tumor. If there is any growing cystic tumor in the pancreas, we can use EOS for the delineation of the lesion. Under linear EOS view, we can identify the cyst and inject the needle and aspirate the cystic fluid. After aspiration, we can inject ethanol again and re-aspirate and re-inject. This is called ethanol lavage. After lavage, if it is necessary, we can instillate small amount of paclitaxel inside the tumor. There are several technical variations. Classic technique is ethanol lavage, but we can modify it as ethanol retention therapy, or we can combine chemotherapeutic agent injection such as paclitaxel injection. This is a 30-year-old female patient showing size-growing cyst in the body of the pancreas, and it caused a compressive symptom, and the upstream MPD is showing dilation. This is at the time of EOS guided aspiration. The size was 3.7 cm, and the aspirate color was a dark brown color, and CA very low, and amylase was 101 unit per liter. Because of growing size and NPD compression, we decided to treat this case by EOS guidance. This is first ethanol injection and reaspiration, second time of ethanol injection and reaspiration, third time ethanol injection and reaspiration. We did ethanol lavage 3 times. This is 2 months after CT scan. We cannot identify cystic tumor here. And this is 1.5 years later. Still, we cannot see any cystic tumor in the body, and the dilated MPD shows normal caliber now, so it is quite successful treatment. This is 58-year-old female patient showing elongated cystic tumor near the body of the pancreas. Upon EUS, it was multilocular cystic tumor and elongated form, and the cyst size was 6.6 cm, and the aspirated fluid was very clear. Ca was less than 0.5, and amylase was 1,174. Triglyceride level was 10 mg per deciliter. We suspected cystic lymphangioma. We decided to treat this case on the US guidance and inserted a 19-gauge needle into the cystic cavity and started aspiration of cystic fluid. The cyst was relatively large, so it took some time. After aspiration, we started injection of 100% ethanol into the cystic cavity. Now we can see the cyst size is enlarged again. After ethanol injection, we re-aspirated the injected ethanol. Now the cyst is collapsing again, and if the cyst is collapsed, it is important to keep the needle tip inside the cystic cavity. And we are injecting ethanol again. The cyst size is enlarged again. You can see echogenic cloud inside the cystic fluid. After initial aspiration of 25 cc fluid, we did ethanol lavage 3 times. These are the amount of ethanol injected, and these are the amount of ethanol re-aspirated. This CT scan is 3 months after therapy. Now we cannot find any cystic lesion. The cyst is completely disappeared. Left side is before therapy. The cystic tumor was very large, but right side is 1.5 years later. We cannot find any cystic tumor on this CT scan. This is another cystic tumor in 26-year-old female patient. Relatively large cystic tumor is observed in the body of the pancreas. Upon EUS, it was a unilocular cystic tumor, and there was no septation inside. The cyst size was about 4.5 cm, and when we aspirated the cystic fluid, the fluid was milky fluid. Ca was less than 0.5, and amylase was 475, and the triglyceride level was 8 mg per deciliter. When we did EUS examination, there was echogenic material inside the cystic cavity. But anyway, we inserted 19-gauge needle into the cystic cavity and started aspiration of the cystic fluid. Now the cyst is shrinking. We tried to aspirate the echogenic material by 19-gauge needle, but it was not possible. Instead, the needle tip was blocked by this material. So we removed the needle and inserted the needle from the different angle and did ethanol lavage. So after initial aspiration of 9.5 cc fluid, we did ethanol lavage 4 times. This is the amount of ethanol we injected, and this is the amount of re-aspirated fluid. To see the treatment response, we tracked CT scan 6 months after therapy. Left side is before therapy. Before therapy, we can see large cystic tumor in the body, but 6 months later, the cyst is completely disappeared. Let me move on to combined therapy of ethanol lavage and paclitaxel injection. This is 56-year-old female patient showing pancreatic cystic tumor in the body of the pancreas. Upon EUS, the cyst showed lobulated margin and daughter cyst inside. And the cyst size was 2.9 cm, and when we aspirated the cystic fluid was viscous. Ca was 10.4 nanogram per milliliter, and amylase level was 4,268. We decided to treat this case by EUS-guided ablation, and the 19-gauge needle was inserted into the cyst and started aspiration of the fluid. We can see still daughter cyst here. After aspiration, we started the injection of pure ethanol into the cystic cavity. Now we can see echogenic cloud formation inside the cystic cavity. The cyst size is enlarged again, and then we started re-aspiration of the fluid. But still, the daughter cysts are visible on this part. Although we are doing ethanol lavage to the large locule, the ethanol effect to these daughter cysts may be minimal, so we decided to combine paclitaxel injection on this case. After initial aspiration of 6 cc fluid, we did ethanol lavage 3 times, 5 cc injection and 5 cc re-aspiration. This was repeated 3 times, and then we injected 1.5 cc, 9 mg paclitaxel injection into the cystic cavity. These CT scans are showing serial changes after ethanol lavage plus paclitaxel injection. The size is shrinking progressively, and the calcification is increasing as the time goes. Left side CT scan is before therapy, and right side is 40 months after therapy. Before therapy, we can recognize cystic tumor here, but 3 years and 4 months later, the cyst is completely collapsed, and we can see only calcified lesion. This is IPMN case in the head of the pancreas. The patient was 77-year-old female patient showing relatively large cystic tumor here, and on MRCP, we can see typical findings of cystic tumor in the head and also tiny cystic tumor in the body. If there is communication between cystic tumor and the main pancreatic duct, there is risk of leakage of injected ethanol or paclitaxel. So to prevent this complication, we decided to insert ERPD stent prophylactically. Upon EUS, the cystic tumor showed lobulated margin, and there was multiple septations. And in some areas, a small mural nodule was also suspected. The cyst size was 5.5 cm, and aspirated fluid color was red-brownish. The cystic fluid Ca was not checked by error, and amylase was 56,290. When we suggested surgical option, the patient refused the surgery, so we decided to treat this tumor under EUS guidance. We inserted a 19-gauge needle into the cystic cavity and started aspiration of the cystic fluid. After aspiration, we injected pure ethanol into the cystic cavity. And then the cystic fluid was re-aspirated. After re-aspiration, we injected ethanol again. This ethanol lavage process was repeated 3 times. We can see echogenic cloud formation inside the cystic cavity. Finally, after aspiration of injected ethanol, we instillated a small amount of paclitaxel into the cystic cavity. After initial aspiration of 15 cc fluid, we did ethanol lavage 3 times. These are the amount of ethanol injected, and these are the amount of aspirated fluid. After 3 times of lavage, we injected 1.5 cc, 9 mg paclitaxel was injected into the cystic cavity. 3 months after, CT scan showed mild size decrease, and 11 months later, CT scan shows further size decrease, but there was suspected pericystic inflammation. Since we sought second time ethanol lavage, we did ERCP and inserted the pancreatic stent through minor papilla. Although we tried major papilla approach, but the pancreatic duct course was angulated and it was difficult to insert a pancreatic stent deeply into the pancreatic duct. These are EUS views at the time of second lavage. On this EUS image, we can observe a lot of echogenic debris inside the cystic cavity. The cyst size was 4 cm in size, and when we aspirated the fluid, it was grossly pus. At the time of second ethanol lavage, we initially aspirated ACC pus-like fluid and the ethanol lavage 3 times. And these are the amount of ethanol injected, and these are the amount of fluid re-aspirated. 3 months after second time of ethanol lavage, we can observe further size decrease here. This slide shows MRCP before initial therapy and 27 months after therapy. When you focus on this body cyst, initially it was very tiny cyst, but during the period it showed the size increase. But when you focus on this main lesion, it showed dramatic size decrease, and we can only see some traces of IPMN on this MRCP. I'm going to move on the results of cyst ablation. We analyzed long-term outcomes after US-guided ablation of pancreatic cystic tumor and reported the result in endoscopy 2017. Initially, 164 patients were included, but 6 patients lost follow-up, so we only analyzed 158 patient response. This table summarizes the treatment response after more than 5-year follow-up. Complete resolution was observed in about 72% of the cases, partial resolution in about 20%, and the persistent cyst was observed in 8.2%. Not all the case shows good response. This is one of recur case. At the time of initial EUS, we can see septated cystic tumor, but we treated this case under US guidance. 6 months after CT scan shows near complete resolution, so we assumed that this cystic tumor will disappear soon. However, 1 year after CT scan shows size regrowth, so we sent this patient to surgery. This is a surgically resected specimen. Pathologically, in most of the locules, lining epithelium was disappeared, only subepithelial fibrous tissue were exposed. But in some locules, there was atrophic mucosa and remnant mucinous adenoma. So initial good response was because of most of the lining epithelium was ablated by US-guided ethanol lavage. But if there is a remaining adenomatous tissue, over the period of time, the tissue will grow continuously. So later, it can show size regrowth after initial good response. Some doctors argued the durability of initial response. Yes, morphologically, initial CR is possible, but is there any chance of recurrence of the tumor? So we analyzed our data. This graph shows clearly, once complete resolution was achieved, even after 10-year follow-up, the recurrence of the cystic tumor observed in only 1.7% of the cases. Based on our own data, I'd like to conclude my talk with this final slide. US-guided cyst ablation can be an effective option for the treatment of cystic tumors of the pancreas. However, careful patient selection and tailored intervention are required to increase the efficacy, to avoid complications, and to maintain the good long-term outcome. Thank you very much for your kind attention.
Really, congratulations, number one. This is an excellent work, and I saw you focus on the cystic lesions and not the lesion, and maybe with injection with alcohol and or without paclitaxel. Just may I welcome my Marseille team, who is looking to you and to your talk, and Alberto, if you agree, just to thank my Marseille team with Marseille and Lebanon, and so Mohamed, Marine, Fabien, Alex, and Janji. So just a few questions. So you focus about injection or not of alcohol and without paclitaxel, and not about RFA, which is also ablative treatment. Why did you do this choice?
Now I understand your point. I am still using ethanol most of the times because ethanol has been used a long time to our clinical medicine, and still it is available widely. And if we combine paclitaxel or other chemotherapeutic agents, then it will increase the effect of ablation. But if the cystic lesion is simple and thin walled, I don't feel we need to add 2 agents inside the cystic cavity. And if we inject chemotherapeutic agents, it will stay there, and sometimes it can create constant irritation and inflammation inside the cyst. So abscess formation is one of the issues after chemotherapeutic agent injection. So I want to do minimal injection, but if I can get good results from ablation. For RFA sites, I am trying to do RFA for honeycomb-shaped serous cystic tumor, while solid and cystic tumor. In those cases, RFA works very well. But in case of thin wall cysts, I still prefer to use ethanol.
So you told us that the main contraindication, the main limitation for injecting alcohol in cystic tumor is the communication with the main pancreatic duct, but it is nearly always the case with IPMN. So I saw you sometimes you inserted prophylactic stenting. So this increases the morbidity of the procedure. So what is your final position about the indication of prophylactic stenting in IPMN? Do you do that in other case? And what about the final morbidity?
If the cyst does not show clear communication, then we don't need to insert pancreatic stent. But if there is communication between the cyst and the main pancreatic duct, I think it's better to insert a pancreatic stent prophylactically. But in our center, we do a lot of ERCP procedures. In a year, we do more than 10,000 ERCP. So the morbidity, we are not very much worried about the morbidity after stent insertion. Sometimes it can create minor pancreatitis or abdominal pain, but we are not very much worried about it because we have done ERCP so many years in this. So, but we should be careful not to insert large or stent. Only the 5 French small caliber stent. That is enough.
And do you use any prophylaxis like NSAID suppository or antibiotic prophylaxis?
we do antibiotic prophylaxis for cyst ablation and also for RFA ablation, because in many cases it may not necessary, but just for preventive and safety issues.
I'm sorry, Don, Juan and Mark, we will have to move on to the next session. Thank you so much for that demonstration, and Mark, for the interactive discussions. We will now move on to the next case procedure number 5. That will be conducted by Vinay Der from India, and Juan Fornals will be the moderator of the session on EOS biliary rendezvous. Welcome.
So this is a lady who had carcinoma of the breast 15 years ago and was asymptomatic after treatment. Surgery was done, and now she has come with jaundice. And on CT, what we see is a lesion at the periampullary region. They did a side viewing scopy and attempted an ERCP outside, and they saw a disease, a tumor. They don't know whether it is a primary or a metastatic lesion, and so they have referred to us for a biliary rendezvous procedure. So this patient is in a good general condition. Otherwise, I was supposed to use the Fuji 580 UT scope here. Unfortunately, in our room, the scope developed some electrical interference, probably because of our C-arm or I don't know what. So last minute, we had to change our scope, and I am using the Olympus GF UCT 180, like you know. So let's start the procedure and see. So just go over the tongue.
Hi, Dr. D. This is Juan Corona from Barcelona.
Hi, John.
Can you explain us your strategy?
So yeah, so the ERCP has already been attempted, so papilla is available to us. In such cases, we always attempt a rendezvous. We will see if rendezvous is possible. Then we will do the rendezvous. So here, you see, can you see the EOS image?
Yeah, very
Doppler.
nice.
Doppler.
You're into segment 2, maybe?
Yes, this is segment 2. You can see there is dilatation of intrahepatic biliary radicals. Let's go a little deep towards segment 3. So you see here, segment 3 also has dilated intrahepatic biliary radicals here. Let's see the porta. This is the hilum. I come towards the hilum. You see a nicely dilated left branch here.
Yeah,
I turn clockwise.
Yeah, 4 or 5 millimeters, maybe.
Yes. Now you see here, I'm at the hilum, distended gallbladder, and dilated bile duct. So we are coming down, tracing it down towards the pancreas. So as I'm tracing it down, it is still dilated. You see here, now we are crossing the SMV and coming in the head of the pancreas region. See, this is quite massively dilated in the distal part. See this? It is quite massively dilated here. And if you see the pancreatic duct, that looks normal. Please. So probably something in the terminal bile duct, pancreatic duct, normal pancreatic duct, hugely dilated bile duct. 17 millimeters. So this is almost reaching till the duodenal wall. I'm just imaging from the stomach right now, and you can see that the dilated bile duct is almost reaching towards the duodenal wall. So it's a distal CBD obstruction. Let's go from the duodenum and see what is happening there. Endoscope. So to choose the site, what we do is we look at both the areas, and I prefer a transduodenal puncture if the position of the patient position is good. If not, then I go transhepatic. So here, trying to go into the duodenum.
So do you prefer intrahepatic or extrahepatic? Do you have a preference, or it depends of each case?
I like transduodenal. I like to do a transduodenal puncture. That would be extrahepatic. So now I am seeing the head of the pancreas, and I turn a little clockwise, portal vein, and this is the bile duct. See this? Massively dilated bile duct. Please.
Very nice view, yeah.
Yeah, so quite significant. It looks like a good patient for a transduodenal puncture. Now I want to show you one thing here, please. Before you puncture, and this is for the young ones who are listening in, see this? There is a duodenal fold here. So avoid these folds if you're puncturing from here till here. So make the duodenum straight. Okay?
So you are in a long skull position now.
Yes, yes.
So,
yes, yeah. So you see this is the tumor. Can you see the tumor?
Yeah, very nice.
That's the tumor. So that is the block.
Tumor, yeah, collapsing the distal CBD.
Yes. So now the position that I like is a semi-long position, and I always like to check on a fluoro. Can you show me the fluoro, please?
Yeah, it can be interesting to see the skull position in the fluoro.
Yeah. So it is looking quite up, not a good position so far. What I will do is now I'll turn the patient flat on the belly, on the stomach, sorry, on the back, supine. That will probably help me get a better position, because right now on fluoro, if you see, the scope is looking towards the hilum, not a great position for doing a rendezvous. So I'm turning the patient to see whether I get a better position here.
Can you send you a question from the audience now? I have one question.
Yes, please. Yes, please.
Yeah,
yes, please.
The question is from Dr. Vanella. It's about what do you prefer, a rendezvous in a malignant disease instead of choledochoduodenostomy or another transmural drainage?
That's a very good question.
It's just the last question, I think. No?
It's a very, very good question. So here I'm planning to place a plastic stent. This looks like a eminently resectable lesion. I want to, if possible, place a plastic stent. And my surgeons, if this patient goes for Whipples, do not like me to do CDS pre-Whipples. Now, this is local preferences. Some places it's not a problem. Some places they don't like. So local preferences, I feel you have a papilla available. My personal approach is to go for a rendezvous first. If it fails and you have no other options, then of course you can always try a transluminal drainage. So the other issue is of the cost. Cost is Doppler. So I'm using a 19-gauge hook needle. See there, and fluoro.
It's a standard needle. It's not the access needle.
No, I don't use the access needle. Can you see the scope position, John?
Yeah.
On fluoro, it's a good position now. I'm satisfied with it. It's looking down towards the papilla. So let us try to puncture this.
Because the guide will go in the direction to the papilla, no?
Yes. So now you see my needle position. It is looking down. It is not looking towards the hilum. We are aspirating bile. It's a dirty bile, dirty dark green bile.
Sorry, Vinash, did you flush first the needle?
Always.
I think it's very important. Flush first the needle, no? Because you can put some bubbles of air inside the 3D and lose the image.
Absolutely, very, very important. So what I'm doing now is I try not to inject and try to see if the wire goes without that, because my needle position is good. If not, then I will inject a bit. So I don't inject contrast. I go by ultrasound view and try to see if we can pass the wire beyond the papilla. So what we are using here is a 032 J-tipped Terimo wire. It's a short length Terimo, 280 centimeters. We find it very useful because the exchanges are very fast. And Terimo is a very, as you know, versatile
It's an angle tip wire or not?
Angle tip, it's an angle tip, yes. What is important also here is the length of needle that you have inside the wire duct. If you have too much length, then the wire may go towards the hilum. See, it is going towards the hilum now. Can you see on the ultrasound?
Yeah, very nice.
Yeah, so we are trying to rotate it down. See on the floor also, now it's went up. So I withdraw a little more so that Bipin gets a little more place to pass the wire. Movements have to be slow. Not too much of wire should be passed at one time, and rotate with your thumb and index finger. Don't push the wire. This would be some of the tips for the youngsters. Go on.
Actually, and your assistant is not using a glove. It's only with the hand. No?
Yes, he doesn't like to use gloves when he's doing all these things.
Do not use a glove?
Yeah, I would say ideally yes. I think we are in the duodenum.
Yeah.
You see this? The wire has gone into D3.
Very
Can you see on fluoro?
Yeah.
Can you see? Yeah.
We can see the loop.
Yes. So we are
going inside the small bubble.
Safely in the duodenum. Now what I will do is I withdraw the needle along with the scope. So first I will withdraw the needle, keeping the wire in place. So here the exchange of the wire is important, because this is a very slippery wire.
Do you think it's possible to see the movement that your assistant is doing with the hand?
Can you show with the camera? Can you change the camera so that Bipin's hands are seen?
Yeah, we can see. I don't know if it's like a kind of a smooth movements or sometimes are quick and fast movements.
Are you seeing Bipin's hands? Yeah. Can you see Bipin's hands? See, he's slowly withdrawing. He's pushing actually in. A lot of wire has gone in. So we are, because this is a short wire, we will have little wire inside, and then we use the saline to float the wire inside the catheter.
So saline to push the short wire.
Yes. So I personally, I know everybody loves the CDS and HGS. I'm a big fan of Rendezvous and Antigrade, probably an old timer. It saves cost for my patients. Now you see what I'm doing?
Yeah.
See, the needle is out. So a very fast exchange is possible with the short wire. Now, the next step is to withdraw the duodenoscope, carefully keeping the wire in position.
But do you need a very expertise assistant?
Yes. Slow. Okay. I think we are safe here. So far, so good.
We have another question about the contrast. Do you think, did you start performing these procedures using contrast? And and with which was the most important reason to decide to not use the contrast?
So in about 5 to, let us say, 7% of patients, we would fail. And then it becomes a sort of emergency. And I don't like contrast inside if we are not able to drain. So I started trying whether I can, do it without contrast. And in majority of cases, now we are not using contrast. We try without a contrast. Of course, if you are going from the hilum, from the transhepatic route, it may be more difficult. But transduodenal, if your needle is nicely looking down, probably you don't need contrast. Especially benign. Rarely we get benign cases for Rendezvous also. It's pretty easy to pass the wire. In this case, the ease with which the wire has passed, I think probably an ERCP would have succeeded much faster, but that's okay. It is. Nowadays, we have both RCTs showing that both procedures are equivalent. So,
and do you have experience using 22 gauge needle and 18 gauge wire?
Very rarely. So the issue here in India is cost. And the problem is if you are using 018 wires, they are a little more costly. And the second thing is I'm very used to this 280 032 Terimo. Very rarely if you have a minimally dilated pancreatic duct or a minimally dilated left hepatic duct and you need to puncture it, yes, it is a useful technique to pass a 22 gauge needle and 018 wire. We also
in benign disease, or when the CVD is smaller.
Sorry?
When the CVD is thinner, maybe you can use
very thin. Yeah.
It was a masterful demonstration. What happens if you cannot pass the wire beyond the structure into the small bowel? What would your tactics then be?
So if you are not able to pass, then one straight option is to do a CDS. Just change the position of the scope and do a CDS. The other thing is if you're going from the hilum, you can do a try an antigrade procedure, because then I use a cystotome. The next case is an antigrade procedure. So now I'm at the G junction. See here, you have to take care that you don't entangle with the wire. Otherwise, it will be very difficult to pull the wire when you are finished with the procedure. So it should not get entangled with the scope. So have a nice look where you're going. See this is the wire. I'm following the wire. This is the wire. And then it is very exciting to see from where the wire has come out. So here you see, careful, please.
It's very important here to avoid a loop inside the stomach.
Yes. So I am trying to go into the duodenum.
The audience is asking again about the type and size of the needle. It was a 19 gauge needle.
Yes.
A Cook Eco Tip, I think, not Eco Tip.
Yes.
19 gauge needle, a Cook needle.
So we do the traditional. This is the mass. See this? This is our wire coming out here. See this? And now what I will do is I'll try to cannulate by the side of the wire. So almost vast majority of buscopan is
Vinay, we unfortunately will have to interrupt you because we need to go on. This was an absolute beautiful demonstration of the rendezvous technique, and we will see you back very soon, and maybe you can tell us about the end of this case. But I take your point. You will try to cannulate next to the wire, which is always easier than trying to extrude the wire to the outside. So thank you very, very much, and thank you, Juan, for moderating this session so excellently. So we're going to move on to advertisements.
Urbet wants to power your performance with a promising technique for submucosal dissection in ESD and POET. Hybrid knife, together with the Vio 3 Precise Sec mode. The Precise Sec mode is provided by the Vio 3 workstation. Fully equipped, it is composed of the Vio 3, APC3, and UrbeJet 2, and serves as a technology platform for standard and advanced endoscopy applications. Urbe's hybrid technology instruments and the FI APC probes are established instruments in flexible endoscopy. Let us focus on the hybrid knife, which combines high-pressure water jet and electric current for all working steps during ESD and POEM. Especially dissecting the submucosa and coagulating vessels in this tissue layer are important steps for which the hybrid knife is ideally suited. The Precise Sec mode, with its dynamic adjustment of the current curve, offers precise submucosal dissection and pronounced hemostasis with little thermal spread. Depending on the contact surface between tissue and electrode tip, Vio 3 pronounces either dissective or coagulative properties. Broad contact causes a rather coagulative effect. Only contact at the tip produces the dissective effect. Dr. Bina demonstrates the use of the Precise Sec mode for submucosal dissection in a step-by-step video tutorial. Watch it on medical-videos.com to learn how to dissect or coagulate vessels using the Vio 3 Precise Sec settings with the hybrid knife.
So we're back. So we start with procedure number 6. So the endosonographer will be Mustafa Ibrahim from Cairo, Egypt. Actually, he will not transmit from Cairo, but he will transmit from Nairobi, Kenya. And the procedure will be moderated by Julio Iglesias Garcia from Santiago de Compostela, Spain.
Okay, you can see us, you can hear us. Okay, hello. So really, this is a very international one. So I'm not performing from Cairo. I'm performing deep in Africa from Nairobi. So really, it's my own pleasure to do this from here. So I have a very international room. So I start just before thanking my friend Alberto Largi. We have Dr. Ibrahim, our anesthesiologist, so really doing a great job. We have a great team here from Softbox doing all of this AV, and we have two helping me, Mustafa and John, and I'm controlled by the two big bosses here. So we have Professor Eddie Igutu, the big king of Ophelia, and we have also the very big king of WEO and Norway, Professor Lars Appelgren. So now we go to the presentation of the patient. So scene number 2, please. Okay, so I have a very interesting patient with hepatitis B, his hepatitis C, child B cirrhosis patient. December on 2021, he had a small gastric varices on OGD, severe portal hypertension, gastropathy. And then 3 days ago, he had the melena here from another hospital in Nairobi. And then I did for him yesterday an OGD, which, second slide, you will see a very interesting picture on the left side. No esophageal varices, this is clear. However, on the right side, on the left side of the image, you can see really a lot of gastric varices. So this is so really you don't know where to inject. This is why I selected this patient for EOS guided injection. So if we can have the scene number 3. So I'm using from Fujifilm. I'm using the linear scope from Fujifilm with an SU1, and so you can see now on my EOS image, this is really the varices. So I'm at the cardium. So I always, if I'm going to treat this, I treat it from the cardium. Again, the difficult question, and I have the big Iglesias here.
Hello, Mustafa. Here from Santiago.
Yeah, very nice to see you twice in 1 month. So
yes.
I will increase my depth a little bit, and you can see here, this is the varices. So I always, if I inject this varices, I inject it from the cardium. So put Doppler, please. You can see we have a lot of them, and this is why really EOS is very interesting in this case. So which one to start? So I will need to choose a big one to start. So I have 2 options. If you put an arrow for me.
Mustafa, just some questions probably for a lot of the people in the audience. Is becoming EOS the first step whenever you want to treat this type of varices, or should we first try and standard endoscopy for blue? What is your impression? And second question, talking about the indications, do you think in an acute bleeding, AUS can be of big help because we don't have the problem of the blood in the working of the space?
This is very 2 important questions. So I start by the second one. So the second one, bleeding gastric varices. So the good thing in EOS that you are not in the stomach, you are treating this from the cardium. So you don't have any problem with the blood. So you see from the cardium, as I'm doing now, you can see the vessel. The problem is not a technical one. The problem is availability. So the availability of an echo endoscopist midnight to treat this patient. So this is the problem. So if we have, and this is why my dream is in 5 years to have this old people really to be able to do this in midnight, because again, this is a very good technique that you can do even if the patient is bleeding. You can assess real time while you are injecting, and on Doppler you can see that you have stopped the bleeding without going to the blood and to the fluid inside the stomach. So going back to the first question, so I will tell you my own, let's say, dream or my own vision. So till date, the gold standard is treating the patient directly with cyanoacrylated injection with a normal needle and a gastroscope. However, what I see, or let's say what I dream of, that the patient will come in midnight. You will stop the bleeder either with one ampoule of cyanoacrylate, just a minimum amount, and then you go to the patient. The patient will be put in vasoactive medication, and then you will do in a clean condition the EOS coiling for all the gastric varices, where you really know what you are doing and where you are doing. And even more, I think that this patient will have, if we go in this direction, this patient will be followed up by a portal hypertension pressure gradient by the EOS. And then even more, now we are doing a very new study of even thinking about injection of the perforator themselves. So I can see this is the future direction, but again, it needs a lot. It needs a new type of endoscopist, who is the echo endoscopist, that he can be available at midnight to do such procedures.
Okay.
So back to just I will show you one thing. Yes, you can hear again. Okay, I'm back to the EOS image. So I'm thinking of, I have a lot of them. So I will be using a 19 gauge needle. Yeah, zoom a little bit from Boston Scientific. So you need an FNA needle, not an FNB needle. I will put an arrow piece from here. I will inject the superficial one there. Yes,
Okay, there's a couple of questions, Mustafa, coming from the attendees. One is, in such mesh type of multiple small barracks on AUS, how do you choose the size of the coil? And that's another question. Do you really believe that's always indication for coil, when we should just put glue plus coil, glue alone? So this I think is a very nice question.
Yeah, it's a very nice question, but again, very early to be answered. So again, the idea of coiling in general that you need to decrease the amount of cyanoacrylate injection, because when you decrease, you have the possibility of decreasing the risk of embolization. Okay. So what I would love, and you see that this is also interesting. If you see here on this vein, for example, it's here, but if you follow this vein, it's continuing down. So it's not separated from each other. So if I'm going to put, let's say, a coil here, back to the question of the measuring, I will measure this one, and I will put a coil. Just freeze this picture, just an example, and measure this coil. Measure this piece for me. Yes. Go to the right a little bit like this. Okay, so I have here a 12 millimeter vessel. So I will put in this one a 10 millimeter coil, with just 5 millimeter of cyanoacrylate followed by this. However, a lot of research work should be done in this part. So we should put coil in bigger vessels and then following this by small injection of cyanoacrylate. But from my experience in Egypt, if I put coil in this one and then after that if I just put a 5 millimeter of cyanoacrylate, please, you will see the continuation of this vein itself will start blocked. So it's not about only putting this. So it's continuing with this one.
Okay.
So now I'm thinking of injecting the big one very proximal to my scope. Okay, so I will ask the 19 gauge needle. So I'm using, as I said, the 19 gauge needle from Boston Scientific, followed by I put a 10 millimeter coil in this one, in the one very near to my probe, and then injecting cyanoacrylate, and then in the second session I will do the other one. So stop, freeze like this. So now today I will do, and this is the beauty of EOSI. You can really see what we're doing. I will do this one, and then in a couple of days, Professor will do this one. So now, and then we will follow this patient again by EOS to see all Doppler effect. So now I start. Remove the Doppler.
Another question, Mustafa, is: did you try to identify the perforator vessel?
Sorry?
Did you try to identify the perforator vessel?
Yes, a lot. But again, in this, especially in this big network of vessels, sometimes it's not very easy. Yeah, but I always try. So we can try here.
Sì. Mustafa? Hi, Mustafa Alberto. Hi, Mustafa Alberto.
Hi, Alberto. How are you?
One question. I saw some ascites. So are you giving some prophylaxis, like some antibiotic prophylaxis for doing the procedure?
For this patient, yes. So this is what goes with the normal varicella patient. So a varicella patient, when he comes with bleeding, we always put him for 5 days on third generation cephalosporin. So already had cephalosporins from 2 days ago. He's on antibiotics. So we should always know that this is our it's a normal patient. So we have a little bit of ascites here. So I will avoid this. Okay. Now it's like a normal FMV. So a normal FNA. I will push my sheath out. Here I put it back few millimeter back. Okay. Increase the depth a little bit. Okay, so now I put the Doppler. Okay, very good. Remove the Doppler. Now my needle is coming here. Yes, I'm inside now the vein, you can see. And now I remove the stylet. I don't aspirate blood, so I remove the stylet. Yes, remove it. And now I will put a 10 millimeter coil. So John is helping me. And the tip is, if the camera can focus on the hands of, this is a 10 millimeter coil from Cook. You open it, please. So the idea, we put the coil is preloaded inside the needle, and then we will put it at the tip of the EOS needle. So now it's don't move. So no one can move. No one should move. So remove this. Remove the security. So we remove the security. We take it. We remove the external, keep the stylet. Yes, remove the external catheter, yes. And then we put it up here inside the needle. Okay, and now we push it by the special stylet of the coil itself, as you can see. And you will see the coil coming. Yes, we push it till the end. And now after that, we will remove the stylet. No, remove, sorry, both of them. And now we will push the coil by a guide wire. I push always either by the stylet or by the stiff part of the guide wire. So I'm pushing by guide wire. And now we need to concentrate on the EOS image. Yes, go. Okay, like this.
Okay, Mustafa, so this is very interesting and some more questions that I need to forward you. One is the vessels, some of the vessels you mentioned look extramural. Do you target also extramural vessels when doing this treatment of varices?
Sorry, could you repeat again the question?
If you also target extramural vessels, yes. Mustafa. Okay.
So I'm pushing now my coil.
Yeah, and just a supportive treatment, do you also go ahead with somatostatin or terlipressin when treating these patients?
Always. So, yes. So I'm pushing by my stylet the coil. So you will start seeing, yes, the coil is coming on the EOS image. You start seeing this whitish echogenicity. So this is my coil coming. I push totally. Very good. Push more. But again, just back to your question, I think there's a lot of studies that should, yes. The coil is coming now, forming. I put few millimeter back to help John. Yes. Push.
Okay. Very nice.
Yes, you can see it. Yes.
Oh, very good.
Okay, push more. So you need just to help him a little bit. I will manipulate just like this. Okay. Yes, the coil is almost forming. And then it's very important to continue. Very slow move, very small movement. You can see it. If you free, just put the Doppler 1 second. You see, even now the part where I put my needle, the Doppler effect is less.
Yes.
So we have less Doppler effect on this part. So he will continue. Yes, I pull back. Yes, he's pushing very nice. Okay, you can see it forming very slowly. You take your time, so you are in, because the only risky thing that when you start having, you should not pull your needle out unless you finish your technique. Okay.
Okay, there's another question, Mustafa. What are the structure of the coils? What is the material? Is it the same that the coils used in radiology for aneurysms?
It's the same vascular coil. You can put a 25 guide wire. So yeah, it's the same vascular coil that they are using for. So it's from and this again another interesting point, that this is a vascular coil which is not sold by endoscopic company, let's say partners. It's from the
radiological partners.
Radiology team. So this is again another important thing that you need to have it in your country. This is from as I said, from the radiology people. So we are pushing now the final part of the coil by a 0.25 guide wire. Yes, it's almost there. Okay. And then after that, so you don't move. You need to inject. I will start injecting. Okay, I'll just try to have a better image, like this. I think now you cannot see. You can see only the whitest thing, so you cannot see any more of the vessel itself. So because it's pushing more, I have few millimeter more, and then I will inject 0.5 ml. Yes, you can remove this, and you can start injecting 0.5 millimeter of science. Okay.
Okay, well, there's a question about how to choose the size of the coil, and I think Mustafa already showed us that you need to measure a little bit what is your target vessels, and according to the size, you will decide the size, same time of the coil.
Yes, yes. And now we could you put Doppler again?
Okay, to Federic.
You see, this is very nice image. Even without the cyanoacrylate, I have no Doppler effect on this. So you have reduced Doppler effect. So again, in the literature, this is a very open question. Should we stop now, or we should inject cyanoacrylate? So for me, to be honest, I was planning to inject cyanoacrylate. However, you see, there's no Doppler effect at the tip of the needle here. So the coil blocked this vein. So what do you think? It's a very open question for you. What do you think? Should we inject or no?
Well, I think if you lose the Doppler effect, you've realized that the coil is very well placed in the proper place. We know that there's the risk of using glue and terapeutico for the scope and for the needle. So if you're confident that the coil has done the job, probably we can avoid putting glue. And that's my opinion. But of course, there's no trials.
I echo you. So I think the coil, because it was a very smooth one, so the coil did the job in this part. So what I'm going to do now, I will pull my needle back, and then I will assess the other varices, and maybe we will think about either a second
Mustafa,
coil in the second. Yes.
How can you be sure now that you are inside the vessels because you cannot see anything anymore? So in my opinion, I would not inject the glue because it would be like a blinded procedure. You know, the glue can go around. You know, can cause emboli. So I in this case, I think the combination of coils and glue is for big varices where maybe the coils are not able to fill in all the varices, and then you put the glue. But in this case, at least for this, I would not do it.
Yes, this is exactly what I did. So I'm happy by the first part which I did, and now the question will be what we should do for this very interesting case. So you can see we have a lot of small network of varices. So
can we have the dynamic view because we have the still image?
Yeah, the still image. No, can you? Yes, you should have the. Yeah, just 1 second. We have the still image.
Okay, there's some questions coming about the risk of embolism. We know that there's a risk of embolism, but we need to balance the risk of embolism with the risk of the bleeding. So this is always a matter of managing the patient and trying to obtain the best clinical decision for the therapeutic approach to the varices. But this is a risk that is there. Okay, now we're again, Mustafa. Now we have the image again.
So I will show you that we still have a lot. So we have only blocked one, which is I will put the arrow there. We have only put the arrow.
So we have 2 minutes to go.
Yeah, we have a lot still of varices. Again, this is the one which is blocked, but however, we still have a lot here, a lot of a big network of varices. So yes, you can see this. This is again another big network. So this is I think this is a very good another indication maybe for this patient for tips.
Yeah.
Yeah, because again you can see that it's very it's a lot of small varices everywhere. So what I will do now, I will assess after that endoscopically. There is a big one here, another big one. Maybe I will think how to inject. I will put another coil in this one now, just to finish this. Yes, you can see I will put another coil in this big one now, and then after that I will go endoscopically to assess. We should follow this patient. And then after that we will see if this patient. We will put this patient on beta blockers, and then we will see if this patient will need tips in the future or more injection. But this is another big one that should be injected. I will repeat this.
Mustafa, thanks a lot for your presentation, for the case, very interesting. Thanks to Julio. I'm sorry we have to move to the next patient. We are already late, so we will go back to. Thank you.
Thank you, Alberto. Thank you, Sal. A pleasure.
Ciao, Julio.
Ciao.
So we have a break.
You may know Fujifilm is a trusted leader in endoscopic equipment, but we have recently evolved to become a complete endoscopy partner from screening to treatment for all kinds of endoscopic procedures. The acquisition of the endotherapeutic device manufacturer Medwork, now Fujifilm Medwork, has significantly increased the width and depth of Fujifilm's portfolio across the endoscopy pathway. For procedures in the upper gastrointestinal tract, which includes the esophagus and the stomach, Fujifilm offers its latest series of gastroscopes. They have excellent image quality, including multi-light technologies which incorporate LCI and BLI imaging modalities and enhanced optical magnification for improved detection and characterization of abnormalities. Even during challenging times like the COVID-19 pandemic, Fujifilm is continuing to innovate, helping to ensure safe and efficient procedures. Unique solutions such as ultra-thin endoscopes to perform transnasal endoscopy help to reduce patient backlogs while maintaining an excellent image quality. With a vision to become a complete endoscopy partner from screening to treatment, Fujifilm now also offers a wide range of therapeutic devices and endoscopic ancillary devices which enable physicians and nurses to perform a wide variety of procedures utilizing Fujifilm's innovative technologies. Solutions for hepatopancreaticobiliary such as ERCP procedures are also redefined, from special endoscope features supporting guide wire-assisted cannulation all the way to stone extractions and other challenging procedures. Small bowel procedures such as enteroscopy require specific equipment to reach deep into the small intestine. Fujifilm's proprietary enteroscopy solution utilizes a specialist endoscope with double balloon technology, the gold standard in performing enteroscopy. It enables the physician to reach deep into the small bowel to perform diagnostic or therapeutic enteroscopy, supported by Fujifilm's new therapeutic device portfolio. Fujifilm's expertise and continual innovation is reflected in its solutions for the lower GI tract, starting with the unique CAD-eye system, supported by Fujifilm's deep learning AI technology Riley, which enables computer-aided detection and characterization of polyps in the colon. When detection and characterization is successful and CAD-eye has identified a polyp, for example a neoplastic lesion, resection can be performed utilizing Fujifilm's endotherapeutic solutions. For more information, get in touch with us via our website, fujifilm-endoscopy.com/contact. Fujifilm, value from innovation.
So we're going to go back to Mumbai in India. Vinay Dir will be moderated by Mihai Rimbas from Bucharest, Romania.
Thank you very much for allowing me to take part of this event. It's my pleasure to reintroduce Professor Dir and his team from Mumbai. I hope he can hear us.
Yes, I can hear you. Good afternoon.
Good afternoon. You know so many tricks, and we could all benefit from this over and over again.
Thank you very much. So thank you, Alberto, once again. The second patient is a 71-year-old lady, large mass in the head pancreas, a large subhilar nodal mass. So clearly unresectable. There is a narrowing at D1, D2. So the ERCP, which was attempted outside, could not succeed. You can see the MRCP here. So nicely dilated left radical, nicely dilated CBD. In this case, I will see if we can do an anti-grade drainage. So I'm sorry, we tried very much to use the Fuji scope again, but some kind of in my room there is some electrical interference. Nothing wrong with the scope, but it catches the electrical interference, so we are not able to use it. I'm using the Olympus scope again. So we go in and we are in the stomach now. You can see the left lobe of the liver. See, there are dilated radicals. Doppler. Yeah, so you have nicely dilated radical. Now if you want to go to D3 to segment 3, you turn a little anti-clockwise, go towards the end, a little tip up, and start coming back, and you will see these are the dilated radicals with us. Here again, see, this looks like a nice dilated radical to go in. See this here. Now here I again turn the patient flat so that I get a good anatomy on X-ray. We are turning the patient, and we will see how is the anatomy on fluoro. Before I puncture, I like to see the fluoro because that helps me know whether I'm in a good position or not. So where is the needle puncture? So you see this. This is a scope position. It looks pretty nice. The scope is bent up, and Doppler once again. We'll do Doppler once again and then puncture. So the scope positioning and keeping the scope in position is very important. Doppler 1 can do. And then once you got it, you have to keep it. Now we are using a 19 gauge needle. Cook 19 gauge. So you see this position is mobile. So my job is to keep the scope steady so that we can at least pass the wire first. And then the same position we should use for the rest of the procedure. If your scope moves away a bit, then we are in a soup. So I'm using the Ecotip 19 gauge. Let's see if the sheath has come out or not. Okay, it's nicely out. Position. It's a very mobile bile duct. See this? So I'm trying to get a good angle so that we puncture nicely without any problem. So here is my needle. I'm using a little up control, sucking fluid, and then gently going. See, it's going in a funny direction. So I change the direction. You see, this is sometimes happens with the Cook Ecotip. I find it bends. And in these situations, I like the Olympus, which is sturdier. So this would of course be because of my angle at which I'm hitting. See, I'm not seeing the needle well here. It's going completely, see here, it's in, but I'm not happy. This is not where I want it to go. So what we will do is we will again try a little peripheral so that we are not close to any vessels. Now I'm at 45 fluoro. Good position again. Now let us see. Now this is not an ideal position that I would like. See, again the needle is bending a bit. So I have to see the needle entering. That's very important, which I'm not seeing here. So I come back and try a last time before I change my needle. I may use the Olympus needle then. Sometimes you may have to reduce the amount of sheath that is inside. So I've reduced the sheath to the maximum, and then I'm trying to see if it goes. So these are individual patients. You have individual issues. Now in this, the major problem is the moment my needle touches the liver, I don't see the needle, which is not a good sign. So let me change the position a bit and see now. No. So I'm close to the tip, to the biliary radical now, but I'm not very sure whether I'm in or not. So I'm see that is the needle position, not very good. So what I will do is now I can see better, but I don't see the tip still. I'll use a Olympus needle now and see whether it gives me a little more stability.
I didn't interrupt because what you were doing was so delicate, but there are some questions about patient's positioning. Is it supine? Yes. Is it on the left lateral?
The patient is flat on the belly.
Okay.
Fluoro?
Do you have the patient intubated?
No. We rarely intubate for these procedures. So now you see the fluoro? This is a good position. I feel we should be able to get nicely. I will try once or twice more, otherwise we give up. Not to try too many times. So this is my Olympus 19 gauge needle, Doppler once again. So safety is paramount. See, this is the Olympus needle I'm using. I think I'm in now. Aspirate.
With this needle.
Yeah, so this is a sturdier needle. So when you have this problem of needle not, all right, I mean, so we are checking whether bile is coming or not coming. Sometimes you feel because of this 2D view that you are in, but you may not be in. So far I'm not. Now I'm seeing bile. You can see bile there. The nice bile is coming now. So it's a position which is a little, not very great. Okay, inject. Now we'll inject contrast. No. This is out. Look. See, it was right on the edge. See here. Now see. Huh? Yes. Now you got the duct. You see the duct? So this is not a great position, but we have got the duct. Now we'll use a 032 Terimo. Fluoro. Yeah. So we are using an angle tip 032 Terimo to go across. It will be a challenging thing because we are quite peripheral. You see, the block is that side, and we have a typical U here. Slowly, slowly. Is it in the back? Because it can move out. So because of respiratory movements, this needle can move out. So you have to be careful. Magnify. Fluoro. जा रहे डक में इजीली नहीं जा रहे. हाँ जाओ धीरे से. नहीं, it's not going smoothly. Now see, I think you are in duck. Withdraw a little, slowly withdraw. So these are all challenges of antegrade procedure. I know we have a very limited time, and sometimes it can take long time. जगह नहीं है अभी. Sometimes you can shear the wire. घुमा धीरे धीरे, ज़्यादा आगे नहीं जाने का. Bring it back. हाँ slowly. हाँ नहीं उस तरफ नहीं जाने का. घुमाने हाँ इधर नहीं जाता इधर. So we are not getting a good guide wire position, although we have injected. So now we'll have to drain. नहीं ऊपर जाने का, नीचे नहीं जाने का. Withdraw gently. I think I'm nicely in. Should not be a problem. ऊपर क्यों नहीं जा रहा है? नहीं जा रहा. So this you need an expert guide wire manipulation, and here because we are not in the ideal place which I wanted to do, we are more peripheral. Withdraw. You are liable to shear the wire. अभी देखो. नहीं लगा नहीं है. So this looks like we are not getting into this radical very easily. I'll try a little 1 minute more, otherwise I'll make one more puncture towards a more dilated part. No. अभी देखो. नहीं वो जाते नहीं. It doesn't go in that. नहीं ना. Okay, let us stop this. Withdraw the wire in. I'll take it out and try another position closer to the hilum. Fluoro. Okay, now let's see. Yeah, we are in the system now. Nice. Go forward gently. Thoda. Very good. Turn now. Rotate. So now we are in the biliary radical, but you'll have to rotate. Very good. Rotate. Yeah, nice. Rotate. So tough proposition, not an easy case. Now दूसरी तरफ. नीचे लाओ थोड़ा. नीचे धीरे नीचे लाओ. अभी नीचे लाओ. अभी घुमाओ. दूसरी तरफ.
Vinay,
yeah.
I don't want to disturb you, but I think in India, this is my feeling because also by going through internet and so on, the technicians are really extremely good. So
you see the wire?
Yes.
Yes, Bibin is happy that he has been able to pass the wire, and we totally depend on them. So we are now in a nice place. We'll try to come till the stricture. पीछे लाओ. थोड़ा सा पीछे आ रहे. नहीं आ रहे. जोर नहीं लगाने का. हाँ, nice. घुमाओ. हाँ, अभी जाओ. No. So this is, I don't know, I find it very challenging, and I often enjoy this whole process of passing the wires.
But this is really a job done by the technician, no? Because it's really the person who is driving the procedure. No? Without a good technician, I think this would not be possible.
No, I think you can do it yourself. Okay, I think now we are at the stricture. Can you see on the CM? Very coil.
Yes, you can see quite nicely.
Shall I withdraw?
Why do you prefer antegrade stenting as compared to hepatogastrostomy?
Yeah, so hepatogastrostomy would have been much easier. I totally agree. But the issue is again of costing. In India, we need cheaper stents. Till we get cheaper stents, we use these uncovered biliary metal stents.
But don't you think also that antegrade procedure leave you a space for a hepatogastrostomy in case then you have a problem long term with the transpapillary stent? So in this way, you have two axes that you can use, no? Because if you do hepatogastrostomy, then you don't have anything left as a procedure.
Yeah, no, you're right. So you must have seen the first case that I did. That was a rendezvous. And the second case I'm doing is an antegrade, and these are my preferences. Patient. Fluoro.
Do you always use a Terumo guide wire?
Yeah, you see how versatile it is? Now I'm going to use a 6-French cystotome position. So always remember on ultrasound, keep seeing the wire. If you don't see the wire, means your position has changed. So it's very important that we keep seeing the wire. And now I'm using a 6-French cystotome by G-Flex. Patient healer. Oh, why is she doing like, no, patient is moving. Again? So as I said, for us here, a uncovered metal stent is cheaper than an HGS stent.
But if you if you would have no price problems or constraint, which stent would you use?
So here I am using an uncovered stent, which is much cheaper. If there is really severe financial problem, we try to even use a plastic stent sometimes. We have the Itoei, the IT plastic stent.
Yes. And if you are a millionaire, which one would you use?
If we are a millionaire, then yes, we can use Axios, we can use the other stents which are available for CDS, and for HGS, yes, we will use the Geobore. Patient is not happy. Patient ko pakad ke rakho. So now we are passing there is some problem. I think somewhere the wire has got sheared.
This is what also a question, because more and more we use the VC glider from guide wire from Olympus.
It's a very good wire, I agree.
And it does not have the problem of sharing, to fill up while you're doing the procedure.
Yeah, VC glide is very good wire, excellent wire.
And it's very stiff actually, even though it is
Yes,
0.25.
It is, see, my need for using Terimo is also the exchange. So I can exchange things very fast. So now here I'm having problems passing the 6 G-Flex cystodome.
Which company is the G-Flex?
G-Flex is a German company, I think.
Okay.
Wire is nicely in position. Fluoro? No. Because this wire. Wire is nice. There's no problem with wire. So sometimes accessories refuse to come out, and we are facing one such problem. So I'm changing the cystodome. And these are all issues which I know. If I did an HGS, probably I would have succeeded in 10 minutes. But this is something I wanted to show you that we can do a transpapillary drainage with equal efficacy. If you ask me in my unit, 90% of my cases would be antegrade and rendezvous. 10% only go for CDS, HGS. So using another cystodome now, let us see if we go through this time. Sometimes the wire.
Sorry, may I?
Sometimes the wire gets sheared.
You were asking a question. Sorry.
Yeah, there was a question about the size of the cystodome. Do you sometimes use a cystodome larger than 6 French?
Never. I've never used it. So there is some problem where there is, I think, some part of the wire which is not allowing this cystodome to go through.
So if you have a long procedure, we have a sort of case presentation about 6 minutes.
Please go ahead. I'll show you the end result.
It's going?
No, it's not going. I'm stuck here. Maybe some part of the. Also, you see the scope angle? It's quite acute.
Okay.
Sometimes. Yeah. Oh, okay. We are in business. You see the wire on ultrasound? That is the key. You have to keep seeing the wire on ultrasound. If you don't see it, there is some problem. Wire under ja raha hai.
Do you have short wire?
Yes, this is the short wire. So I'm hoping that the cystodome comes out. So far it has not come out. Wire under ja raha hai. So there is now the cystodome has come out. Now we see the cystodome. See this? So I think now we are in business.
Okay. So now you needed to speed up. I'm just putting pressure on you. I'm joking.
So we are burning the liver here.
We don't hear the current. Do you use current or?
Yes.
Which electrosurgical unit do you use?
So we have the RB quadri, RB Vio 3.
Quanto siamo indietro?
Loro?
Vinay?
Yeah.
Can we transmit a video of 5 minutes while you are searching?
Yeah, please.
So we give you all the time for you to work, and then we'll come back in 5-6 minutes.
Yeah, sure.
So we search for a patient for a necrosectomy. Unfortunately, necrosectomy comes and goes, so we did not find one. Direct endoscopic necrosectomy has always been a very cumbersome procedure performed with accessory taken from the endoscopy and the ERCP armamentarium, baskets, snares, and other stuff. So it was a very, very long procedure with a lot of time lost. I remember one patient, it took me basically 3 sections of 6 hours each, so basically 18 hours. I couldn't stand anymore. Nowadays, in the last few years, we have 3 new dedicated devices that have been built up for endoscopic necrosectomy that are in order of release into the market. The endorotor from Interscope, the excavator from Ovesco, and the necrolith from Endovang. Sorry. So we don't have a patient, but we will present a video of about 5 minutes presenting all of these 3 devices in the order I said. Okay, the video can start.
We report the case of a 77-year-old female. In March 2022, she developed acute necrotizing biliary pancreatitis. CT scan performed 5 weeks later demonstrated a 16 per 10 cm walled off pancreatic necrosis. EOS-guided WOPN drainage using a 20 per 10 mm lamps was thus performed. However, because of persistent fever and sepsis, direct endoscopic necrosectomy was scheduled. This is the CT scan demonstrating a very large pancreatic collection with high necrotic content inside. Endoscopic necrosectomy can be now performed with several different newly developed dedicated devices, such as the endorotor, the excavator, and the necrolith. The first one is the endorotor system by Interscope, which is an endoscopic marcellator device. It is available in 2 sizes, the 3.2 and the 6.0 mm catheters. In the video, you can see that abundant necrotic material blocks the central portion of the previously positioned lamps. The 6 mm endorotor catheter is placed exactly inside the saddle of the stent. The rotating system is then activated, and the necrotic material is broken and suctioned into the catheter through the vacuum system. This allows to perform the necrosectomy under direct endoscopic view and to avoid intracavitary vessels. One important point to consider when necrosectomy with endorotor system is anticipated to be performed is to place the lamps in the gastric body towards the antrum in order to avoid angulation when entering the collection that can break the endorotor catheter. The 6 mm catheter has a 3 times larger window and an 8 times higher capacity to extract tissue than the smaller catheter. The 6 mm catheter can be only used with Olympus Give XDQ 160 scope or with any therapeutic gastroscopes by using a side accessory channel. The smaller catheter can be used with endoscopes with a working channel of at least 3.2 mm. The second device for endoscopic necrosectomy is the over-the-scoop grasper excavator by Oisco. It is a grasper mounted over the scoop with a scoop span of about 28 mm. It is suitable for gastroscopes with an outer diameter between 9.5 and 10.5 mm. Once mounted, it adds about 4 to 5 mm to the outer endoscope diameter, and its passage is possible only through lamps with a diameter of at least 15 mm. The device is mounted outside the patients over the tip of the gastroscope and then secured to it. The necrotic material inside the collection is aspirated or grasped inside the scoop. Then the scoop is retracted into the gastric cavity where the necrotic material is released by opening and closing the scoop and with the help of the dedicated forceps. The last new endoscopic necrosectomy dedicated device is the Necrolith by Endovang. It features a double lumen catheter which allows two devices to coexist inside, a monofilament loop and a retrieval basket, each of them with their own reference handle. The special monofilament loop has a diameter of 9 mm, has an ultra-stiff ends with a rounded tip to avoid traumaticity, and a flat internal section to improve grip and cut potential. The basket has equivalent width and length. It consists of nitinol filaments that provide variable flexibility for improved retrieval capacity, and comes without the tip to reduce trauma. The spiral steel core that connects the handle to the basket has a small diameter in order to give a fast rotation, called helix effect, which allows a quick detach of the necrotic material. The device allows to interchange the monofilament loop and the basket without the need for accessories exchange, thus reducing the duration of the procedure. Given its ability to grip and cut, the loop is mainly used to perform necrotic material mechanical fragmentation, while the basket is particularly useful to grasp and remove the necrotic material.
So we saw the video of the three necrosectomy devices. They have a different concept. One is the concept is to fragmentation of the necrotic tissue and aspiration through a vacuum system. The second one it's more grasping and then taking out the material out from the necrotic space from the inside of the collection. And the third one put together two accessories that were used before, so the basket and the snare, with modifications that allow to be able to take necrotic material better than if you use a normal basket or a normal snare. Materials inside the necrotic cavities can be completely different. So there are filamentous material, very hard. Not always one device can work for itself. But the fact that we have three different devices can help to basically take care of any type of this walled-off necrosis. So I think we should move. If India is not connected, we should move to Belgium. If it's not connected, they had problems. So they're connecting. Okay, so the problems are solved. So we saw, it's good live transmission. You sometimes look at very good things, but you also can watch problems. In this case, probably the problem was a sharing of the guide wire that basically impeded the cystotome to advance. And also, even if it wasn't advanced, there was a difficulties. And this, I think, underlined the fact that we need a development of accessory, whatever type, dedicated for US procedure. Because, for example, some guide wires that are okay for ERCP are not okay for US. So we can go to India to finish the case. Otherwise, we have to move. They are there.
One last comment and question. It seems like this is a very delicate procedure. It's not for everybody. I'd ask Professor Deer to share with us his opinion about training for such a procedure.
Excellent. Thank you. So we had a major problem, as you saw, with the guide wire. So we have used a fresh guide wire, and now we are going into the bile duct. No. So we are now at this picture. We'll coil the wire just like before. Now let's hope that this time things go okay. Is
this a different guide wire than before?
No, same guide wire. I think we are close to the duodenum now. Should I withdraw? So I'm withdrawing the needle now. So I think the thing with Terumo is it's a very sensitive wire, and if it gets torn or sheared, then the whole thing becomes very difficult. Gently, fluoro. Yeah.
Deny.
Yeah.
Can I ask you something, because I lost what did you do to overcome your problem? Because I think sometimes we show very nice cases that seems very very easy in our hands or in hands of the experts.
No, so in this case, the problem was the accessory. So the G-flex cystotome was not going smoothly over the guide wire. So we thought that probably the wire is kinked somewhere. Fluoro, please.
What did you do?
So we used another guide wire.
Okay.
A fresh guide wire.
So you left the cystotome, take out the guide wire, and go back to another one.
Yes. But so now what we are doing is, fluoro. I think now we are in a very safe position to place a stent. We can even do an HGS also if this fails. It's okay, don't worry. Nikano. So you see, we are using the water push technique to because we are using a short Terumo wire, and we use a small syringe to push water into the needle. And sometimes it works, sometimes it is not working. Now it is working very well. Sure. Okay, so this is out. We have the guide wire in hand. Now let us see. Cystotome, brand new cystotome I want. Now on ultrasound picture, you see there, the wire is nicely in place. And we will use a fresh new 6-French cystotome in the hope that this one will go without a problem. Let's see. If it doesn't go, then I think you go to another case. So those who are watching this should not get scared that it is a very complicated procedure. Sometimes these things happen, but most of the times you are Wire. Okay. So the cystotome is this time out very smoothly. Okay. So now we are at the stricture. Wire withdraw. Okay. Try to pass it. Try to pass it. आराम से. Floor. I'll bring a little up. अभी देखो. नहीं. नीचे दूसरी डायरेक्शन में. ऐसा घुमा. हाँ. Yes, that is the direction. Let's go. धीरे 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 धीरे. So we are almost through now. नहीं घुमा. तो कुछ क्यों करता है? घुमा. घुमा दूसरा डायरेक्शन में. Towards the duodenum. Are we through? Okay. Can you see we are in the duodenum?
Yes, we can see very clearly.
Let us inject some dye to see that we are in the duodenum. So we'll just inject some contrast to confirm that we are indeed in the duodenum and not somewhere else. Yeah. So that is the duodenum. Now we remove the pterimo and put a stiff wire.
There was a question about the water jet technique. If you could
yes,
some more about it.
So basically, you have a short wire which finishes before you withdraw the whole assembly. So then what you do is use a small 2 cc syringe and put it at the mouth of the needle, and then use force to force the saline into the needle. Once that happens, then the wire floats. The wire floats in the saline, and very easily you can pull out the assembly and the needle very fast. So we find it very, very useful because it saves so much of time. Chalo, withdraw.
Is it useful for inserting, for example, a cystotome over the guide wire as well?
Yes, for everything. I mean, even when we are placing stents through ERCP or other things, we are using we are using this technique only because for us it looks like it saves a lot of time. Now here, as I can see, there is one acute angulation over which the stent has to go. Rest of it looks probably smooth. So one last step, placing of the stent.
How do you choose the size of the stent?
So I think this is a head pancreas, subhilar block. So a 6 or an 8. I would probably use an 8 here. So we are using the wall stent, the Boston Scientific wall stent. Before I use that, I have to always see that I can see the wire on ultrasound. If I can't see the wire, then I am in a wrong position. So I should not attempt placing the stent. So always on the ultrasound, see that you are seeing the wire. So it's an uncovered stent.
Another question is, at the end of the procedure, do you need to close the gap in the gastric wall?
That's a very good question. We normally don't close because you see there's a lot of liver between my puncture site and the biliary radicals. So at least 3 centimeter liver is there. It acts as a very, very good buffer. For
we need to move, but how long is it going to take you to place the stent?
Just give me 2 minutes.
Okay.
Give me 2 minutes and we will be through. This is the last step. Okay.
I was more worried about the gastric perforation than the biliary peak.
No, as you know that from our experience of Axios and other things, the small and even when you're doing DJ, they heal spontaneously and we really don't have to do anything much. So now I'm at the stricture, you see here. So that can be one area where there can be little problem. I'm pushing the stent, so far very little resistance, going pretty straight. I think I'm now, careful. So
it's giving traction.
Looking satisfactory so far, but you never know. Inject. So the last part of pulling is remained.
Vinay,
so
1 minute because we need to move. I'm sorry, but we are 20 minutes behind.
Let me see if I can just push it across. So the last part of the tumor is causing resistance. So I'm using gentle forces to see if it goes through, and it is so far not gone through. I'm pushing it gently to see if it goes. I think it is going gently. Okay. I think we are in the duodenum. Inject. Are we in the duodenum? Huh? Very good. Or inject. So we are through, Alberto. We are just going to place the stent in 1 second now.
Yep.
Put out contrast. I want to see the position of the papilla here. So now we are freely in the duodenum, as you can see. Okay, deploy. The advantage of this uncovered stent or the stent that we are using is that you can redeploy. You can close if you're not happy with the position. So you can redeploy it.
Now you're happy.
Yes. Nicely in the duodenum.
You're happy. We are happy.
Thank you for bearing with me. There are technical. Deploy.
So today we learn from you. I think that you really need a good technician to help you out with this difficult procedure, because they look, when you look at a rendezvous, it seems easy, but then it can be easy, but it can be also more very difficult. So I think if you do everything by yourself, it can be double difficult. So I think the culture of guide wire manipulation in India, you cannot find everywhere in the world. So there are only a few places where they do the same. So I think we really need to close with the connection. So with the case, I really thank Vinay and I really thank Mihai. So it's all Vinay and Mihai for being here with us. And
thank you very much. I really enjoyed.
Thank you really for your availability all the time.